Awesome. Thank you, Kayla. I know this is the last talk of the morning, but hopefully this will be entertaining for all. So my name is Becca. I'm an R2. I'm in the primary care track in the women's health pathway. And I'm going to be talking to you all about cervical cancer screening today. And these slides are adapted from a resource I'm working on with a few other UW faculty for teachim.org, which I would highly recommend checking out if you're ever curious to just find some good chalk talk material or anything like that. Yesterday was International Women's Day, so I know not all women have cervixes and not all those with cervixes identify as women, but hopefully this will be a relevant topic for everyone, and it'll be a nice review of some info and maybe some new teaching points as well. I'm going to ask Kayla to look at the chat because this is my first time doing a Zoom presentation, so please interrupt me, Kayla, at any point. I have no conflicts of interest. And here are my learning objectives for this morning. So my hope is that by the end of this talk, you'll be able to describe HPV virology and its role in the natural history of cervical cancer. You'll then be able to choose the appropriate screening tests and intervals for patients who are at average risk for cervical cancer using one of two guidelines that we'll discuss. You'll be able to apply ASCCP 2019 risk-based guidelines to manage abnormal results in average risk folks. And then finally, you'll be able to identify high-risk populations and apply an alternate screening and management guideline. So beginning with a case. You are in your continuity clinic and you have a wellness visit with a patient. It's a 37-year-old person with a cervix with a past medical history of lupus on hydroxychloroquine, and they're here for their annual wellness visit. They report they had a normal pap smear 3 years ago, but they're not sure if HPV was tested at that time. They completed the HPV vaccine series. And they ask you, when am I next due for my pap smear? What is a pap smear and what happens if my results are abnormal? How much longer do I have to keep doing pap smears? And my hope is that by the end of today's talk, you'll be able to answer these questions. So starting with some background pathophysiology, we now know that persistent infection with high-risk forms of HPV virus, chiefly type 16 and 18, cause almost all cases of cervical cancer. There are more than 150 different types of HPV, and among those, about 40 of which can infect the cervix. There are 15 that we call oncogenic or high-risk strains. As you all are likely aware, HPV infection is very, very common, especially among healthy young adults. And there's a significant rate of transient HPV infection, particularly in this younger population. For example, about 70% of new HPV infections are undetectable within a year and about 90% within 2 years. However, there is a small percentage of infections that persist, leading to precancerous changes and then ultimately progressing to cervical cancer over a period of years or decades. Factors that increase the risk of persistent HPV infection include infections with those oncogenic subtypes of HPV, such as 16 or 18, older age, immunosuppression, which we'll dive into a bit more later, such as having HIV or being on certain medications, smoking. It's believed that the breakdown products in cigarette smoke actually concentrate in the cervical mucus and impair immunity. And then lastly, infection with other STIs or using birth control pills. Although I'll say this last one, it's unclear if it's correlation or causation. A quick review of cervical anatomy. So as you all will hopefully remember from 1 year of med school, the ectocervix is lined with squamous epithelium, while the endocervix is lined by columnar epithelium. And where these two areas come together is called the squamocolumnar junction. The transformation zone is a small region of squamous metaplasia, which again, harkening back to earlier years, is when the columnar epithelium is replaced by squamous epithelium. And that occurs at the squamocolumnar junction. It seems that the HPV virus preferentially infects squamous epithelial cells at the transformation zone. They typically start at the basal layer of cells and then spread vertically. HPV infects cells by inserting its DNA into the epithelial cells, which then leads to an increased replication and production of oncoproteins that inhibit tumor suppression genes and lead to uncontrolled replication and resistance to apoptosis. This is important because about more than 90% of cervical cancers do develop at the transformation zone. So it's vital that when you're performing a pap smear in clinic, that this area is sampled during screening. And given the distinct cellular linings of the cervix, malignancy that arises from the ectocervix will be squamous cell carcinoma, representing about 75% of cases, while malignancy arising from the endocervix will be adenocarcinoma, which is much less common. Cervical cancer screening seeks to detect treatable changes and precancers that are likely to progress to become invasive cancer. And over the last century, screening has been very, very effective in reducing the incidence, morbidity, and mortality of cervical cancer. There are 3 available tests that you can use for cervical cancer screening. There's cytology, or the pap smear, primary HPV, and co-testing. So cytology, which we call the pap test or the pap smear, is when cervical cells are collected with a swab and then they're examined under a microscope for changes that are suggestive of acute HPV infection, precancer, or cancer. Primary HPV testing might be a bit newer to some of you. This is a test that detects the DNA of high-risk types of HPV in a sample that's taken from the cervix. And most of these tests are further able to genotype the sample to identify if it's HPV 16, 18, or an other high-risk genotype. And then finally, co-testing is when pap smear cytology and a primary HPV test are performed at the same time to detect high-risk forms of HPV. One note I want to give as we move on with the screening guidelines is that anytime a primary HPV test is performed and results positive for HPV, regardless of the genotype, that sample should have additional reflex cytology testing performed. And that might be a familiar concept to you. It's somewhat similar to the idea of cytology reflexing to an HPV test. And then one other note I'll give is that many of the guidelines use the language HPV-based testing, and that refers to either a primary HPV test or co-testing. So beginning with screening of individuals that are at average risk for cervical cancer. As I mentioned, our recommendations have really evolved over time, and it's largely due to our improved understanding of the natural history of cervical cancer, the causal role of high-risk HPV infection, and our changing technologies. So today I want to review with you 2 different currently available and recommended guidelines. The first is the USPSTF 2018 guideline. This is the one that will probably sound familiar to you all. It's the one that I learned in med school and the one that appeared on USMLE testing. And then the second might be a little bit more newer to folks. This is the American Cancer Society, or the ACS 2020 guidelines. And I want to underscore that either of these are acceptable methods when you're screening average risk individuals. So beginning with the USPSTF, this screening guideline recommends that in patients who are ages 21 to 29, you perform cytology only, or a pap smear, every 3 years. And then in folks that are 30 to 65, you can either choose between cytology only every 3 years or an HPV-based testing, again, meaning either primary HPV or co-testing every 5 years. The reason this group doesn't recommend HPV-based testing in those less than 30 is because, as I noted, there is a high prevalence of transient HPV infection in this age group. However, cytology alone has been found to be less sensitive for precancer and cancer, especially adenocarcinoma, interestingly, compared to HPV-based testing. So that's why this method is recommended as an alternative in the older group of patients. And then additionally, what's nice with the HPV-based methods is they can space out screening to every 5 years because of the higher sensitivity for these changes and the longer preclinical phase from a high-risk HPV infection to the development of a precancer lesion or cervical cancer. This is in contrast to the ACS 2020 guideline. This one is a little bit simpler in that it's the same recommendation for all patients. So the ACS 2020 guidelines recommend beginning screening at age 25 through age 65. And for all patients, they recommend first choice being a primary HPV testing every 5 years. And then they say co-testing every 5 years or cytology every 3 is an acceptable alternative method. The reason this group has the change to start screening at age 25 is because they found that cervical cancer incidence and mortality was very low in the group less than age 25. In that less than age 25 group, they said there was a high prevalence of HPV, as USPSTF noted, but they found that those were often transient infections that didn't cause persistent cytologic changes. And they felt that screening that younger group led to unnecessary treatment and associated harms, including possible adverse obstetric outcomes. As I mentioned earlier, primary HPV testing is more sensitive than cytology alone, which is why this group favors using primary HPV-based testing instead of cytology in women in the 25 to 29 age group. They believe that it will lead to more life years saved, although they do note that this is at the cost of possibly additional colposcopies. And then moreover, they recommend primary HPV over co-testing because they say it's a more efficient method, and they argue that co-testing offers really little incremental value compared to a primary HPV approach. The one big caveat that I will give here and that the guideline does admit is that, as I said, co-testing and cytology are acceptable alternatives because at present, access to primary HPV-based testing is very limited. There are only 2 currently FDA-approved primary HPV-based tests. What both groups do agree on is when to stop screening. So both groups say that you should stop screening at the age of 65 in a patient who's at average risk and does not have a history of CIN2+ for the last 25 years, and they've had adequate prior screening in the last 10 years. What does adequate mean? And I will warn you, this is often hard to find in EPIC or in CPRS when you're doing your chart review. But adequate technically means 2 consecutive negative HPV-based tests in the last 10 years, the most recent of which is in the last 5, or 3 consecutive negative cytologies in the last 10 years, the most recent being in the last 3 years. What about folks who have had a hysterectomy? So in patients who have had a total hysterectomy, meaning that the cervix was removed, and this was done for benign indications, and they're outside that 25-year window if they've had a history of CIN2+, you can also stop screening in these patients. Transitioning now to speak a little bit about high-risk patients. As I alluded to earlier, high-risk patients are those with immunocompromise or who are immunosuppressed, likely due to different medications. This group does include folks who have a diagnosis of HIV, and cervical cancer screening guidelines for persons with HIV have been very well supported by evidence from both retrospective and prospective studies. And it's currently recommended that you use the CDC's guidelines for screening in folks with HIV. Unfortunately, patients without HIV who are immunosuppressed, there just is not as much consensus and clear guidelines for these patients due to a lack of quality evidence. The best recommendation that we have currently comes from a publication that was done by a panel of healthcare professionals that are involved in cervical cancer research and patient care. And they propose that you can think about patients who are immunocompromised but don't have HIV as falling into one of 2 groups. One group of those patients they think should follow the CDC HIV screening guidelines, and the other group can follow the general population guidelines. And what this paper proposed is that the patients who should follow HIV screening guidelines are those with a history of solid organ transplant, hematopoietic stem cell transplant, folks with lupus, or folks with a history of inflammatory bowel disease or rheumatoid arthritis who are currently on an immunosuppressive drug. Interestingly, this paper suggested that folks with IBD or RA that are not currently on immunosuppressive therapy actually can follow the routine general population guidelines. And then folks with either type 1 or type 2 diabetes can similarly follow guidelines for the general population. So what are the CDC guidelines for patients with HIV? They currently recommend that in patients who are less than the age of 30, that they undergo screening with cytology every year for 3 years until they're all consecutively negative. And then at that point, they can space out to every 3-year cytology only screening. They suggest that screening should start at the age of diagnosis, but not before the age of 21. And they recommend cytology only because of the high prevalence of HPV in this age group. Once folks are above the age of 30, they can then either switch to co-testing every 3 years or cytology every 3 years. And if they had not undergone those 3 in a row every 1 year in an earlier age group, they should do that in this age group as well, if sticking with the cytology only method. The other big difference that I'll highlight for high-risk patients is that screening should continue throughout a patient's entire lifetime, not like with the general population ending at the age of 65. The asterisk there being that, of course, this is with shared decision-making and taking into account a patient's general life expectancy. And what about this population when they undergo a hysterectomy? So similar to the general population, the CDC suggests that when folks undergo a total hysterectomy for a benign cause and they have no history of a high-grade CIN lesion, there's no need to continue screening. However, if they do have a history of CIN2+, they do recommend annual vaginal cuff pap testing. And then I added a little bit of information here too. This comes from Up to Date. It's not the CDC guideline, but Up to Date put in their article that's their clinical practice in folks with HIV if they develop progressive HIV or that if they're unable to obtain viral suppression while on therapy, then they also recommend continuing pap screening annually with cytology or co-test.
Becca, we just had a question pop into the chat. Adam asks, after age 30, why would you choose to do co-testing if there's not recommendation for reduced testing? Seems like it's just more costly without a benefit to the patient.
Yeah, really good question, Adam. I think it would just be, I guess, I don't have a good data point for you, and I don't remember in the guideline if they thought there was added benefit. I guess the co-testing then does provide more information on HPV. And as I said, we do know that HPV-based testing does have higher sensitivity than cytology. But I hear you. It is interesting that it doesn't give you, unlike the general population, an ability to space out to every 5 years. So perhaps more costly, but also perhaps maybe more sensitive for detecting changes. Great question. Okay, I want to pause here. Ooh, another chat. Oh, thanks. Great. Thanks, Adam. I want to pause here to talk a little bit about some health equity concerns. So there are disparities that exist really along the entire cervical cancer care continuum. And although, as I said, HPV vaccination and screening programs have really overall led to a downtrend in the incidence and mortality of cervical cancer, there still unfortunately are marked disparities among some of our population's most vulnerable communities, including racial and ethnic minorities, socioeconomically disadvantaged, and persons who reside in rural and isolated areas. There is so much data on this out there, and I tried to just highlight a few statistics that I thought were particularly striking. For example, according to some SEER data from 2012 to 2016, cervical cancer mortality rates among Black women in the US were 3.5 per 100,000 people versus 2.2 among white women. And Black women had a 58% 5-year survival rate for all stages of cervical cancer compared to 71% for white women. Another example from the US with this same database showed that overall the cervical cancer incidence in the US is 7.6 per 100,000 people. But this varies from the highest being in Arkansas at 9.8 per 100,000 and the lowest being 4.1 in the state of Vermont. I also wanted to just pause for a moment and think globally. In 2020, worldwide cervical cancer was the 4th most common cancer in women, but 84% of those cases come from resource-limited regions. For example, on the continent of Africa and in Central America, cervical cancer is the leading cause of cancer-related mortality in women. And then I also wanted to highlight a really interesting practice advisory that was released by ACOG in April of 2021 after the new ACS 2020 screening guidelines came out. And I wanted to highlight just 2 points that they put in this advisory statement with regards to a larger health equity concerns. And so the first was their concern about this use of primary HPV testing, and the second was related to raising the age of screening initiation. So as I mentioned, although ACS says you can still use cytology-based options, they also advocate in their guidelines an eventual phasing out of cytology-based screening in the near future. And ACOG, which I see the point to, they feel like this is a problematic statement because currently the areas that have the least access to these primary HPV-based testings are those communities that are lower SES, communities of color, and those that have been geographically isolated. So ACOG argues that until these primary HPV-based testings are more widely available and accessible, cytology-based screening should remain an option for all patients. And they say it's less about the specific strategy selected and more about consistent adherence to the routine screening guidelines. Sorry, I forgot to make my animation go. The second point here they bring up is this how ACS recommends changing the age of screening to start at age 25. And as you all will know, vaccination and screening is sort of our first opportunity to prevent and intervene early before folks develop cervical cancer. But unfortunately, nationwide, our HPV vaccine coverage and screening rates are still below goal. And it's unfortunately in this less than 30-year-old population that we see the lowest screening rates. So again, just some sort of salient disparities that I wanted to call out with regards to vaccination. Earlier studies back in 2017 in the post-ACA era showed that at first there were lower rates of vaccination completion among Black, Latina, and Asian communities. I will say more recent data has shown that there's been a steeper increase in vaccination uptake, and the racial and ethnic disparities have somewhat narrowed. There also still seems to be this very large geographic variance in vaccine coverage, and it tends to be lowest among non-metropolitan areas and women without health insurance. You can tell I thought these state statistics were really interesting, but in 2018, it was found that in the age group of 13 to 17-year-olds, HPV vaccination rates were only 38% in Kansas and Mississippi, but were more than 70% in Washington, D.C. and Rhode Island. And then similarly, screening rates, we still see persistent racial and ethnic disparities among screening uptake. So in the US, Asian and Hispanic women are less likely than non-Hispanic whites to have been screened for cervical cancer. Another study found that women who were uninsured, immigrants, had lower educational attainment, or lived in rural as opposed to suburban areas, didn't have an established PCP, all tended to have lower cervical cancer screening. And in the US, it's the southern states in particular that unfortunately have the highest proportion of women who've not yet been screened in the last 5 years. Some folks point to perhaps lower number of providers in these more rural areas, as well as a higher rate of uninsured folks, partially due to lack of Medicaid expansion in these regions. And then I just want to also comment that there are a number of barriers to cervical cancer screening that can be both personal as well as secondary to real structural obstacles in both accessing care and in experience of healthcare. So given these two sort of highlighted areas, ACOG still continues to recommend starting cervical cancer screening at the age of 21, with the fear that starting later will just further decrease the uptake and worsen existing disparities. So what can we do as primary care doctors? The first, I just want to make a plug for talking to your patients about HPV vaccine. I know ideally it would be happening more in the pediatric population, but I would say I have been really surprised by how many of my patients have not been vaccinated and have never had a provider talk to them. And just a plug that you can vaccinate all the way up to age 45 after some shared decision making. And I would recommend having your patients check with their insurance as well to make sure it's covered. And then second, an area I'm hopeful could potentially help increase screening uptake is the idea of a self-selection. Sorry. Sorry guys, I've lost my ability to make my slides advance. Sorry, 1 second. Let me let me stop sharing and reshare for just a second. Okay, can you see my slide still? Okay, awesome, thanks. So the second area I hope will help is the opening more of self-collection options for HPV samples. Especially I think in folks who have faced barriers to screening, folks with limited healthcare access, gender minorities, and those with a history of trauma. I think this could be a really viable option. It's not yet FDA approved, but self-sampling is available in the Netherlands and Australia. And basically patients can self-collect samples from the vagina using a tampon or a cotton swab, a cytobrush, or even lavage. And in the US, there's been already one RCT that did show that having this as an option to patients did increase uptake of screening as opposed to just usual care. Okay, I see the chat. Let me pull it up real quick. Okay, great. Thanks for the plugs, guys. So transitioning now back to the topic of management. And this is an area that I
We
felt
did
like,
actually have a question pop in late. To clarify, self-sampling would just be HPV testing and not cytology.
correct. Great question, Gina. Yeah, because it's from the vagina, it would be HPV screening. And I think you could think of it somewhat similar to FIT testing, that you'd have to give the caveat that if this is positive, you'd likely have to come back for a pap smear with cytology. But yeah, great question. Okay. Now going to a bit more on the management of abnormal results. And this is something I felt like I did not really have any teaching on. So the first question I would recommend you think about when you're managing pap smear results is asking yourself if your patient is average risk or not. And we'll talk a bit more about high risk individuals shortly. But once you've decided that you are in the average risk category, I would recommend that you use the American Society of Colposcopy and Cervical Pathology, or the ASCCP 2019 Risk-Based Management Guidelines. And what's really nice is that this is available as an app for pay. I would give a plug to primary care future providers out there to think about shelling out for this one, but it's also free online on their website. And what this tool does is it interprets HPV and cytology results as well as colposcopy biopsy results if they're available to help you decide on the appropriate next steps. So I think it's sort of nice based off our last talk on lipids. You can think of this as almost like an ASCVD risk score. You put in the information you have and it tells you what the next step should be. And these guidelines are based on the principle of equal management for equal risk. So they follow this risk-based rather than a results-based approach to determine the best next steps of management. And specifically, they ask the question of what is a patient's immediate risk of CIN 3+. If that risk is greater than 4%, you'll go down one pathway, and if it's less than 4%, you'll go down another. This tool is based on data from a prospective longitudinal cohort study of 1.5 million patients from Kaiser Permanente, Northern California. And they estimate your patient's risk using their current screening test results, any prior test results and biopsies results, as well as personal factors like age and immunosuppression. So for example, if you've had an HPV infection present for a longer time, that will increase your risk of CIN3 being present. And then additionally, as we've talked about, certain kinds of HPV like 16 or 18 may also impact your risk. So after you punch in your patient's information, if it finds that their immediate risk is less than 4%, the tool will then help you determine the appropriate surveillance interval. Whereas if the tool finds that their immediate risk of CIN3 is higher than 4%, they'll suggest the next management step. So going down the surveillance arm, if the immediate risk of CIN3 is less than 4%, the tool then asks what's their average 5-year risk of developing CIN3. If their risk is less than 0.15%, they can come back in 5 years for repeat screening. If their risk is 0.15 to 0.55%, it then recommends 3 years. And then if it's above 0.55, they should come back in 1 year. And I just want to promise you don't need to memorize these numbers. I'm just kind of showing you the brains behind the tool right now. In contrast, if a patient's immediate CIN3 risk is greater than 4%, the next step is determined by the overall size of that risk. So in folks that have a risk of 4 to 24%, they would be recommended to undergo colposcopy. And that I thought there being that a colposcopy can help confirm whether CIN3 is present prior to proceeding with treatment. In folks whose risk is 25 to 59%, the tool will recommend either colposcopy or expedited treatment. And this is really based on shared decision-making, predominantly based on whether a patient desires future pregnancy. And then if a patient's immediate CIN3 risk is 60 to 100%, it would recommend expedited treatment. And expedited treatment is treatment without first undergoing colposcopy for those that are very high risk. Treatment options include cervical ablation, which would be cryotherapy, CO2 laser, or thermal ablation. And then excision would be cold knife cone, loop, or leap, or a laser cone. And then finally, hysterectomy is also an option. I'll just make a note here that excisional treatment is generally preferred over ablative treatment, especially for folks with histologic HSIL, because the tissue can be taken and then pathology can be obtained. So a brief reminder about what are the differences between a pap smear and colposcopy, and what are the results you might get from these studies. The sample that's collected during a pap smear, as we talked about earlier, is reviewed by a pathologist and a cytology report is generated. And that report, in that report, it will tell you whether there was a presence of any abnormal changes or suggestions for acute HPV infection, precancer, or cancer. So some possible cytology results that you might receive, and I'm going to try to order these roughly in the order of increasing prevalence of abnormal cells. You might receive a result of negative for intraepithelial lesion or malignancy, atypical squamous cells of undetermined significance or ASCUS, low-grade intraepithelial lesion LSIL, atypical squamous cells can't rule out a high-grade squamous intraepithelial lesion or ASC-H, or atypical glandular cells, and then finally high-grade intraepithelial lesion. In contrast to a pap smear, colposcopy is an in-office procedure, and during which the cervix is examined under a high-power microscope called a colposcope, and then acetic acid is added to the cervix to help identify any abnormal appearing areas that should undergo biopsy to further rule out any precancerous or cancerous changes. So when that biopsy is performed, the sample is reviewed by a pathologist and a histology report is generated. And histology, as you might remember, refers to the examination of tissue architecture under a microscope to look for the amount of vertical extension of abnormal cells, as depicted here, as well as staining for P16, which is a tissue marker of HPV oncogene overexpression to help determine the histologic grade. So when you get a colposcopy report back, the possible histology results might include no carcinoma in situ or no CIN, histologic LSIL or CIN1, histologic HSIL or CIN2 or 3, or adenocarcinoma in situ. And then it is possible you could see invasive cancer as well. Management considerations I want to briefly just touch on in folks who are at higher risk. And again, who are we talking about here? We're talking about folks who are immunosuppressed, as well as patients who have a history of CIN2 or CIN3. So in patients who are immunosuppressed, because of their increased risk, you can go onto the ASCCP web or the app, and there's actually a special situation tab you can click and select the immunosuppressed population. And this is a nice quick resource to use. But briefly, the biggest difference between this population and the general population is that colposcopy might be indicated for folks who have ASCUS and HPV positive results, or anyone with LSIL or worse findings, regardless of an HPV status. And then in patients who have a history of CIN2 or CIN3, these patients do require both an increased short-term and then long-term surveillance. So the short-term surveillance depends on the treatment that a patient undergoes. So if a patient still has a cervix, it's recommended that they undergo an HPV-based testing at 6 months, but it's not necessary to do that in folks who undergo a total hysterectomy. And then both groups should have 3 consecutive annual HPV HPV-based testing before they transition to more long-term surveillance, which would include HPV-based testing every 3 years for at least 25 years. Throw out a little nuance here. I think we typically say 25 years. I will note that the guidelines make a point that some patients might determine they want to continue screening even once they're outside of that 25-year range. And that might be a reasonable decision to make. There have been some long-term population studies that show that your increased risk of cervical cancer does continue beyond that 25-year period. And it might actually be highest among folks that are above the age of 50. So as with the general population, really, once you make it beyond this 25-year zone, doing very thoughtful shared decision-making and taking into consideration patient goals as well as their just overall health and life expectancy. And then the life expectancy is a reason to discontinue. Okay, I know that was a lot of information. Thank you for making it with me to this point. My hope is that we can do a few cases and be a little bit more interactive and let you guys put some of this information to work. So our first case this morning, and if you are feeling so bold, please unmute yourself or put your answer in the chat. I'd appreciate any support from y'all in participating. So our first case that we'll go through together, you are in your continuity clinic and your patient today is a 40-year-old person with a cervix. They also have a past medical history of hypertension and depression, and they're here today for cervical cancer screening. They had a co-test today in clinic that was negative, and they have no prior history of abnormal pap smears. So when should they be screened again? Awesome. Thank you all for being brave. Shout out to the primary care cohort folks. I recognize these names. Awesome. Exactly right. Because they had negative HPV-based testing, they can be rescreened in 5 years. So this patient comes back 5 years later and they have repeat screening. This time, their primary HPV-based testing comes back with HPV positive for a high-risk strain other than 16 or 18. So it reflexes to cytology and they're found to have ascus. Now, what do you do? And I'm going to make a plug. If you're feeling brave, please go to the website. Yes, Gina, use the app. Amazing. So if folks have time, I think we have time to try it out. I would say try going to this website if you don't have the app already downloaded on your phone. I think when you go to this website, they might ask you to enter your email. So I'm sorry about that, but they don't spam you. I can assure you of that. Is anyone going through the process? I'll give a little bit of time if they are. I see Kevin already answered us in the chat, but wanted to give folks some time to try using it if they'd like to. Okay, for the sake of time, I'm going to continue. Kevin, really good guess in the chat. And I think this actually would have been what we used to have recommended. But what's interesting is now that we have more data and we're using this risk-based guidelines, we actually would recommend that this patient just come back in 1 year for HPV-based testing. And so just walking through how I got this answer in the app, I selected the age group of 30 to 65. This would be routine screening because it's been within the last 5 years. And you'd enter high risk HPV other and ascus, and it will spit out this result for you. Yeah, Jed, great job. Jed used the app for the website. So perfect. So at 1 year, the patient comes back, you repeat testing, and it shows the same thing. They still are HPV positive other, and they still have ascus. Now, what do you do? And I know at least Jed is using the website, so I'll pause for a little bit to see if folks are plugging this in. It's a little bit clunky because you have to restart, but you should be able to plug in these PAP results. Awesome. And I see Leah in the chat, exactly right. It's a colposcopy. So now, because they've had this year surveillance, the result has not changed. Their risk of CIN3 is high enough that they recommend colposcopy. The patient undergoes colposcopy and the biopsy shows CIN2. What are your next steps of management or follow-up? And I think for the sake of time, this one I will just give you all the answer for. I think for most of us in internal medicine, colposcopy may not be a part of our practice, although it certainly can be. But this might be more falling within the realm of our OB/GYN colleagues. And so I just want to show you this one because I think it is highlighting a different part of the app where you will use no longer the screening section, but the evaluation of a colposcopic biopsy. And if you plug in our patient's information, it actually will give you two options for treatment. And so it will say you can do treatment followed by the HPV-based testing that we talked about. Or if your patient is really considering becoming pregnant in the near future or has concerns about how treatment could impact future fertility, it's also reasonable with shared decision-making to have them undergo observation with colposcopy and HPV-based screening in 6 and then 12 months. And then just in general, how would you counsel your patient on the impact of what a history of CIN2 will mean for their future recommended screenings in the future? No one's feeling brave on this one. So just a reminder, having a history of CIN2. Yeah, awesome, Gina. Thank you. So in the short term, it will really depend on what treatment option they elect to do. But just as Gina said, in the long term, these individuals really are considered at higher risk for developing cervical cancer. So they'll require screening at 3-year intervals. They'll never get to go back to the 5-year interval. And this will continue for a minimum of 25 years. And I would say this counseling has been something that's newer to me, but is really relevant for, I think you'll find, a surprising amount of your patient population, either because of immunosuppression or because of this history. Okay, and then last but not least, as promised, the case that we started with. So returning to this case, our 37-year-old patient with lupus, they're here for their annual visit. They had a normal pap smear 3 years ago, but they don't know if HPV was tested, and they completed the HPV vaccine series. So when and how should this individual be screened for cervical cancer? Yes, amazing, Gina. Thank you for participating. Yes, they should be screened today. And screening can be either cytology alone with a pap smear or HPV co-testing. Again, getting back to Adam's question, still don't have a great answer for you, but either of these would be an option for her, given her history of lupus. Pap smear is done and it comes back LSIL, HPV negative. Now, what is your next step in management? So for those of you with the app open, you can click the special situation tab, you can click on immunosuppressed, and then you can maybe find the answer there. But because of the history of immunosuppression, in this patient population, they do recommend colposcopy now, given the finding of LSIL, regardless of that HPV negative result. And then finally, they ask you, when can I stop screening? And hopefully now you all can counsel them better than you could before. But the answer is, because of this patient's lupus, you're going to recommend that they screen throughout their entire lifetime, not getting to stop at the age of 65 as you would in the general population, assuming that they are in reasonably good health. Okay, thank you all for everyone who participated. Just some take-home points today. Just final reminders that we really do now have a better understanding that it's persistent infection with the oncogenic subtypes of HPV that cause almost all cases of cervical cancer. Routine screening of average risk folks can be done with cytology alone or HPV-based testing. And either of the guidelines we talked through are great for use, and they agree about stopping at the age of 65. I hope you feel better equipped to manage abnormal results now and use that ASCCP app or website. And then just keeping in mind that patients who have immunocompromised or immunosuppressed are at higher risk for HPV-related cervical cancer, so they have unique screening and management protocols. And I will stop there.
Wonderful. Thanks so much, Becca. We will maybe give a couple minutes if folks have any last questions that filter through, and then everybody can head off for their day.
Awesome. Thanks, Kayla.
Thank you. Great talk.
All right, have a great rest of the afternoon, everybody. Bye.